Good evening, everyone. Thank you so much for joining us. Good evening, everyone. So I just wanted to remind everyone that it's a professional environment and we ask that everyone remain respectful towards all participants. The webinar is being recorded and it may be published for others to view at a later date. If your screen name is different than your name registered for the CME, please rename yourself to match your name claiming the CME. If on an audio only connection, please text me at 602-909-4388 with your name to confirm your attendance for claiming your CME. You can see and hear us, but we cannot see or hear you. The webinar is best accessed through computer. Utilize the bottom bar to submit any questions through the question and answer function. Questions of the presenters, please use the question and answer feature on Zoom to ask your questions. Questions posed in the chat may be missed. Our moderators will moderate the Q&A and pose questions to panelists if the time is permitting. If your question is not answered at the end of the session, we will work with presenters to follow up after the conference.
And welcome, everyone. So our esteemed president of the Arizona Psychiatric Society had to step off for a patient emergency. Or are you back?
I actually just
got back on.
Okay. Everything is handled and okay. So if it's all right, I'd love to still do that welcome.
Yep, go right ahead.
I just want to say thank you to everyone for joining us tonight for this 988 and how to access the Arizona crisis system webinar. Well, we're thankful that Arizona has a robust crisis system, and it's important that we continue to learn how to maximize the power of 988. So I'd really like to give a warm welcome to our panelists and speakers who are joining us tonight and thank them for their time. First, we've got Dr. Margie Balfour. She's the Chief of Quality and Clinical Innovation at Connections Health Solutions. We have CJ Loisel, Crisis Administrator at Arizona Healthcare Cost Containment System, or ACCESS. We've got Andrew Irwin, Chief Operating Officer at Solari Crisis and Human Services. Tanisha Hildebrand, Crisis and Veteran Services Administrator at Mercy Care. And I've gotten a sneak peek of some of the things that she talks about. We did a presentation in Gilbert last week for an interfaith summit, and it was fantastic. So really grateful for her time. And then finally, Johnny Gasper, Director of Justice and Crisis Systems at Arizona Complete Health. And with that, I'd like to turn the time over to Dr. Balfour.
Great. So let me get mine going up. So I'm going to be starting us off with a really brief overview of just crisis services in general, what's going on nationally, and then why Arizona is being looked at as a national leader. I mean, there's always room for improvement, of course, but as the nation is really starting to build crisis services and think about this, there's a lot of strengths in our system that sometimes we're not aware that other states don't have. Because every day in America, in most places, there's this huge disparity in how we deal with mental health emergencies versus other types of medical emergencies, where if you call 911 and say you're having chest pain, you immediately get dispatched an ambulance with people who were trained to take care of of the condition that you have, and they take you to an emergency room with people standing by ready to treat you as soon as possible. Whereas if you have a mental health emergency, the default first responder is often law enforcement. And there's many reasons why this is problematic. A quarter of officer involved shootings are linked to mental illness, because you're sending, police officers to respond to people rather than, people who are trained to take care of what they need. Oftentimes people end up in jail instead of getting the treatment that they need. Emergency rooms aren't that great of an alternative either. Most emergency rooms in the US don't have psychiatric services available. And so without any way to treat folks, they end up basically put on a list to be transferred out to a psych hospital somewhere. And so they call it psych boarding. People can be boarding for days, sometimes even weeks in some communities, waiting to be sent to a hospital to get the care they need, which is problematic for both for the system, but also the patient experience. So the Substance Abuse and Mental Health Services Administration, or SAMHSA, they've laid out a vision for a better way to be responding to mental health emergencies, built on 3 pillars. The first is someone to call, which is 988, which is a crisis line, which you'll hear about in much more detail, that provides an alternative to 911, where someone can help try to resolve your crisis, and then someone to respond. So first responders, other than law enforcement, clinicians who can meet the person where they are in the community and provide crisis intervention. And then a safe place to go for people who need to be in some sort of facility as an alternative to an emergency room, a place that is really set up to address and provide treatment for people with mental health and substance use emergencies. And so 988 is the first of these pillars, and 988 went nationwide. It launched in mid-July of 2022, so just a couple of months ago. And what 988 does is it's basically a 3-digit dialing code like 911 that connects to what was the National Suicide Prevention Lifeline. So that's that 800 number that you would see at the end of TV shows when there was a suicide trigger. And Andrew is going to talk about it in much more detail, how it actually works. But this network of call centers is able to provide like a standard level of care where people get crisis counseling, safety planning, get connected to resources. But 988 is just the tip of the iceberg. So this schematic on the right kind of shows where all of the mental health emergency calls are. And the Lifeline is part of it, but there's a lot more out there. And so 988 is really thought of as a first step on a larger journey to create a better system for mental health emergencies. Like today, we can't imagine 911 without automatically thinking about all the stuff that goes with it. So emergency EMS and ambulances and fire and level 1 trauma centers and all of that. And this is an opportunity to start to build out a comparable system for people who have mental health and substance use emergencies. So what happens after the call? Well, a lot of that depends on where you live. So for the ideal outcome, if you call 988, you need to connect to a call center that's in your local community that has access to all the local resources and that can connect you to those next 2 pillars if you need that, someone to respond, mobile crisis, or be able to refer you to crisis facilities and get you connected into local community, outpatient mental health systems and things like that. But there's a lot of challenges to that. One of the main ones is that currently the way the calls are routed are based on the area code from your phone, not where you actually are. So if you're like me, and I kept my old cell phone when I moved to Arizona, if I called 988 from my house in Tucson, I'm going to get a call center in Texas. And while, I'm sure they're nice people, they can't send me a mobile team to Tucson. So that's one problem. There's also the performance of the call centers varies widely across the country by state. This map here shows the first full month of data from 988. And so Arizona's green. So yay, thank you, Andrew, for making Arizona green. But a lot of call centers aren't able to handle the call load and answer their own state's calls, and they may be sending those calls to a backup center in another state. And then the crisis services that exist, the someone to respond and the safe place to go. Most states don't have a lot of those services. So right now, the response you're going to get is going to depend on where you live. So that's why there's so much momentum right now nationwide around building crisis services and a lot of attention on this. And there's really a lot of converging developments that's created this momentum. There's 988, but there's also, the pandemic really highlighted the importance of mental health. It's one of the few issues that truly does have really, really strong bipartisan support. And the police reform movements too, like there's lots of things that still disagree around police reform, but one thing pretty much everybody agrees on is that police don't need to be the default first responders for mental health. So as these guidelines and best practice toolkits and things like that come out, a lot of them are citing the Arizona model as a model to emulate. And so why is that? What's so special about Arizona? Well, there's many reasons why Arizona is special. Our number of venomous animals being one of them, but our crisis system has been developing over the last 30 years. We have probably one of the oldest and most mature and robust crisis systems in the country. This map here shows where all of our 23-hour observation units are, which most a lot of states are just starting out and building like their first one. Or it's still on paper. They haven't even started doing that kind of thing. And here we have like 17 of them. And one of the reasons why it's been so successful is that there's been investment over all these 30 years, because it really is a good example where the clinical outcomes that we want as clinicians are really aligned with the financial and the funding incentives as well. Because what we want as clinicians is, I want my patients to not be in the emergency room or jail or, admitted to a hospital if they don't need to be. And if you're paying for stuff, you want that same thing, because it's a lot less expensive to be doing well in community-based care than it is in those other levels of care. Another key feature of Arizona, an innovation that lots of people are looking to, is how we use our Medicaid system. No other state uses their Medicaid system to form the backbone of the crisis system like Arizona does. And CJ will tell you more detail, but some of the key features of that is that everyone in Arizona is entitled to crisis services, no matter what your insurance, if you have insurance or not, or even if you're just passing through. And one of the reasons Arizona is able to do that is because they combine funding from lots of different places. So there's all the Medicaid funding, which is the bulk of it, but also the federal block grants that come from SAMHSA, state and local funds for crisis and indigent care. And in many states, it's different departments that have each of these pieces of funds, and they don't talk to each other. And then Access, our Medicaid, they contract with our regional behavioral health authorities, which you'll be hearing from both of them later in the presentation. And then they are responsible for coordinating the system. And in many states, you'll go ask, well, who's responsible for the crisis system? And they'll go, well, everyone is. Well, if everyone is, kind of no one is. With our REBA structure, the Regional Behavioral Health Authority, they contract with all of us providers like me and Andrew at Solari and, Community Bridges and RI and, all the other different crisis providers. And then they are responsible for making sure that we all work together and align ourselves to decreasing people, being in jail and emergency rooms and hospitals. And they're kind of like the conductor of an orchestra with all of us as the pieces. Another way to look at that is you can think of our services aligned in this continuum of with least restrictive, most community integrated on the left, which is also the least costly. And then at each step, the whole system is set up to try to make it easy for people to get their crisis resolved in the community as much as possible. So you've got our crisis lines, which is 988. They're able to resolve most of those on the phone. This is data from Southern Arizona, but it's about the same across the state. For crises that can't be resolved on the phone, we've got our mobile crisis teams that can do face-to-face interventions out in the field. And then for people who need a higher level of care, we have our acute crisis facilities like in Phoenix, like, we have the UPC, the CRC and Tucson, and there's many others like on that map. And those facilities are really designed to be someplace, an alternative to the emergency room, where over the course of an overnight observation stay, we try to resolve that crisis and prevent them from having to go to the hospital if they don't need to get and rather get them connected to the community resources that they need. And most people can have their crisis resolved in that way. And then there's services after the crisis to help keep people stable. So post-crisis wraparound services to make sure that people get connected, crisis residential that can be like a step down if people need a little bit longer for their crisis. And then because we're also trying to prevent people from ending up in jail, at every point along here, it's integrated with the justice system to try to divert people out of the police jail pipeline into the treatment pipeline. So many of the 911 call centers in the state have crisis line staff that are co-located there. Mobile teams respond, to law enforcement. Some of them are incentivized to respond faster to law enforcement. And then our crisis facilities are really meant to be faster and easier for police to drop someone off there than to take them to the jail or the emergency room. So they get all this training on how to divert people to treatment, and then this sort of makes it easy for them to do the right thing. And then I won't go over this whole slide in the interest of time, but the point of this is that as our system evolves, what we're working towards is a true collaborative system where you really only involve law enforcement if there's a reason, if there's a safety risk where they need to be involved, because the rest of crisis should be the responsibility of the behavioral health system. And there's many ways to do that. And that also, in addition to the acute crisis, that our services need to also make sure that people, as their crisis is resolving, get connected to what they need, and with the outreach and follow-up, they can prevent future crisis episodes. So with that, I will hand it off to Andrew to talk about Solari and 988.
Awesome. Thanks, Margie. You did a great job of giving that overview. Let me get my deck pulled up. All right. Everyone see that okay? CJ said yes.
Yep.
So like Margie said, Solari is the front door to the crisis system. So we're the ones that are receiving the calls through 988 and our statewide 10-digit number. So we've been doing this for 15 years now, since 2007. We're nationally accredited through the American Association of Suicidology. And we operate the crisis lines in both Arizona and Oklahoma. We just started operating the crisis line in Oklahoma, and it's really for the reasons that Margie was talking about earlier. The system in Arizona is now considered a best practice blueprint. So lots of folks are trying to emulate what we've done in Arizona. So we're able to go into Oklahoma and essentially help them try and take some of the ideas that we have here in Arizona and implement it there. We are one of the highest call volumes in the United States. So we're taking probably around 30,000 to 40,000 calls in total across Arizona. And we'll talk about that a little bit later, but it is by design. We've been operating very different in Arizona for a long time and saying, we want all kinds of behavioral health calls to come into our crisis line through that front door. We can connect people with those mobile teams and then get them into facilities. There's been a lot of states that have thought about the suicide prevention lifeline as simply a suicide hotline. Arizona's been very proactive in saying that we want people to come to us early in a crisis, and that's going to help us resolve it better for the individuals in our communities. So just to sort of get a baseline understanding of what I talk about when we're talking about a crisis contact center, SAMHSA sets out what are minimum expectations for those crisis contact centers. So at a minimum, we need 24/7, 365 coverage. This isn't something where we can have set hours. Crises are not going to follow our usual 9 to 5 work schedules. We have to be overseen by clinicians. That is the best practice. There are a lot of contact centers that use volunteers. The crisis line here in Arizona is overseen entirely by clinicians that are full-time employees. We answer every single call and coordinate overflow coverage with the resources that meets all of our crisis contact center expectations. We assess risks of suicide in a manner that meets national suicide prevention lifeline practices. So when our staff is on the phone with somebody, they're actually working through a risk assessment model that gives us a score on each individual that calls into us. We coordinate with mobile teams. So we have access to all the mobile teams in Arizona, and we're the ones that are dispatching them out when necessary. And then we have the ability to connect individuals to facilities. So we're able to coordinate with them as well, get transportation so that those individuals can get connected to those resources. So on top of those minimum expectations, there's best practice expectations on top of that. And so what SAMHSA is looking for is caller ID functioning, the ability to collect data out of the phone system directly into our electronic health record. have GPS enabled vans. So when we send out our mobile teams, we're actually able to see their location. We're able to send out the team that's closest to the individual that needs that assistance. And we're also able to monitor them for safety reasons about where they are and how long they've been in a particular location. Regional bed registry technology, we're actually implementing that now in Arizona. So this is our final step, and then we'll have all 4 of these. But the concept is that we can see bed availability at all the facilities that are in our communities so that we can direct people to the most efficient place for them to get the resources that they need. And then finally, we help individuals schedule outpatient follow-up appointments. We do that through warm transfers to their providers and ensuring that they're actually getting those appointments. So this is a dashboard on our website. We're going through the process of updating it to include all the 3 regions of Arizona. Currently, it just has 2 of them, the North and the Central, but it gives a good sense of the type of metrics that we have here. We're trying to have our answer rates be similar to 911. So when somebody calls into 911, the expectation is that that's live answer and they're going to pick up the phone really fast. No one's getting placed on hold. There's no like push button system. So in the top left corner here of our benchmarks, you can see that we pick up the phone in 3.86 seconds. So that's about a ring and a half. So that's just like one little beep. And then the average delay, if somebody does have to be put on hold, at 7 seconds, and our abandonment rate is less than 1%, meaning that when people call in, there's only less than, that's 0.1% of individuals hang up before able to speak to them. Again, we're doing that at very, very high volumes compared to a lot of other states. The example that I always give is that here in Arizona, we're doing around 30,000 to that 40,000 calls in a given month. The state of Oklahoma is going to do around 30 to 40,000 calls in the entire year. So it's just a different system that we've built here, really driving people to be connected to our resources. One of the major drivers, aside from having sort of this general concept of people calling in for whatever their behavioral health needs are, is that we do have access to resources. So when we look at other states across the country, lots of them don't have mobile teams. Lots of them don't have those facilities that Margie was showing us before. And so if you don't have those resources, then the only thing that you can really get through these phone lines is the assistance over the phone. And so because we have that full robust system behind this system of who you can call and talk to, we have a lot of individuals that are calling us saying that they know that they're going to need the assistance of a mobile team, and that's the resource they're looking for, or they need coordination with an inpatient facility. So that really does drive a lot of phone calls to us. So Margie also touched on 988 coming. This has been a massive change. People that work in this space have really been pushing for 3-digit dialing for at least the past 5 to 7 years. This has really been an initiative that all of us said that this is something that's going to put these emergencies on par with 911. We're going to be able to draw away a lot of those emergency calls that are currently going in at 911 and getting a law enforcement or an EMS response, when really what they were in search of was a behavioral health response. So there's some differences between the 2 systems that we have here in Arizona, and I'm going to talk about those a little bit. But on the left, SAMHSA is the one that runs the 988 crisis line. So they're the ones that help set that up and promote it. We work with the team at Access in terms of getting funding through SAMHSA to set up that line. So that system, if somebody's calling into 988, it's being routed through a SAMHSA contractor, and then it's sent over to Solari. And we're given assistance by La Frontera Impact in answering those calls. On the right here, we also have 10-digit dialing to call directly to our Arizona crisis line. And that is set up through our regional behavioral health authorities. So Access provides the funding to the REBAs, then the REBAs contract with us to operate that crisis line. What we really did here in July was set up the system so that Solari is overseeing both of those lines. So both 988 and the 10-digit dialing through the REBAs. And so that way there is coordination of care. There isn't going to be a different experience between the 988 line and the 10-digit number, at least once they connect to one of our operators. So there are some key differences, and I want to point those out. Margie was talking about earlier that if people call into 988 and she's got her Texas number, she's going to be routed to the very nice people in Texas and not to Arizona. So that is an issue with the current system. They are trying to work through what we're calling geo routing. And what that would be is that the system would function like 911, even though Margie's got her Texas number, the system would be able to identify based off of her location that we should be connecting to Solari because she's in Arizona. So currently the way the system functions is if you have a 310, a California area code, they're going to call into 988, they're going to be routed to California. California will attempt to stabilize that person. If they can't and they need a mobile team, they'll actually call Solari and then we will assist them in dispatching out a mobile team. That is not a great scenario. It's one of the drawbacks to 988 at the moment. But the big thing that we're getting with 988 is the national coverage. People are now aware that 988 is an option. That's a better connection than 911. If they're not aware of their local numbers, they can call that number and they'll get connected to somebody that'll get them where they need to go. Now, with our 10-digit number that we have through Access and the REBAs, those individuals would be able to call directly into that 10-digit number and they're going to speak to Solari in those metrics that I talked about earlier. So they're automatically going to speak with one of our staff. They're not going to go through a push button system. It's not going to be routed off of the area code. It'll come directly to us and we'll be able to begin the triage process of assisting them. So a little bit of a difference. The way I really have been describing it to people is that if they don't know that 10-digit number, 988 really is that entry point into a crisis system to try and connect into the resources. If they do have access to our 10-digit local number here in Arizona, give that to them, have them utilize it, let them know what the resources are, and they'll get directly connected with us. I do like to show this graph because it does show the data around what our behavioral health system is versus that 988 lifeline. So you can see the vast majority of calls coming to Arizona are through our REBA system. So that 10-digit system that we've used for forever, for over 15 years, really produces a lot of call volume. So we're seeing 40,000 calls in August. And there was only 4,000, so that's post 988 implementation, 4,200, close to 4,300 in July to our 988 number. So we do have good access to our communities. Our community members are aware that those 10-digit numbers are out there for their resources. They're programmed into people's systems. They're aware that they can call and get those services. I just put it out there so people have context. I anticipate over time that we are going to see this number grow and it will get larger as 988 gets more traction. But we can see that our 10-digit system here in Arizona is functioning very well. Just as I said before, we have a really broad idea of why people should be calling into the crisis line: depression, anxiety, coordination of care, self-harm, danger to others, substance use. If it's a behavioral health issue, call us. We'll help people sort out where they need to go next. And that philosophy really has driven up those numbers in terms of people being able to have this call center be their first step in addressing their behavioral health needs. When individuals call in, this is what they can expect. We ask them for their name and date of birth. They don't have to give that to us. We will ask for their phone number if it doesn't show up in the caller ID. Again, they can remain completely anonymous if they want to. It is live answer when they call into our 10-digit line, and it will be when they're routed through 988 to one of our staff. So they're going to be speaking with one of those individuals very quickly. They can remain anonymous. HIPAA applies to all these conversations. So if people have concerns about confidentiality, we can let them know that it's the same experience that they would have speaking to any other behavioral health clinician. We want people to know that they can access the system as quickly as possible, that the point of this is to be an entry into the system. It doesn't have to be a quote unquote crisis. If they have behavioral health needs, we are that resource for them to call into, and we can help them where they need to go. And then also they can call into us for third-party information. We're able to connect them to those resources if they're uncertain what the next steps are. So Margie did also mention our 911 diversion program. Again, Arizona is a leader in coming up with different ways to partner with law enforcement. The way that we went about that was integrating our staff and processes into the 911 dispatch centers across Arizona. So currently we have staff that work in the 5 largest 911 dispatch centers. And what we did is we trained every single dispatcher on what calls they needed to transfer over to Solari because they were behavioral health related. We were able to sort of create this continuum. So caller dials 911, 911 determines if there's an immediate risk, 911 operator determines if it's a mental health crisis, 911 operator decides if an officer is needed. If not, they can transfer the call. If an officer is needed and a mobile team, they can contact us and then we'll co-dispatch with them. Really, the difference between us and a lot of other models is that we're leveraging the crisis system that Access has built. We're lucky that here in Arizona, we have the crisis contact center access to mobile teams. So 911 is able to transfer those calls over to us, and we're able to quickly get out our mobile teams without even having to send officers. And when those officers need support from the mobile teams, we're able to do that code dispatch. At this point, I know we're sending around 4,000 calls that are being transferred from 911 contact centers over to us. So those are all situations where probably 90% of the time the response would have been a law enforcement officer going out to interact with that person or an EMT. Neither one of those is going to deal with the long-term issues that individuals with behavioral health crises actually need addressed. So we really are combining a situation where we're putting the best tools into the hands of these individuals to try and address these issues. We also operate our dispatch system. So this is actually a screenshot of our GPS system. So each little flag is a mobile team that's out in the community. We're able to see all of the mobile teams that are up and available at any given time. So we could have 40 plus mobile teams available to us in a given day. So on the very right side of the screen, what we see is the teams that are available, the ones that have been dispatched. And then on the left, we're able to click into the notes and actually see what's going on with that individual. We built this system internally at Solari, and it's what we use to coordinate with our mobile teams. The system works kind of like an Uber, where we send out a dispatch to the team. They get directions through Google Maps as the application. So turn-by-turn directions, and we're able to see where they are every 2 minutes. The system updates. In addition to that, what we've done is we've integrated with the mobile team providers so that the note in our electronic health record is the note that they're reading in their electronic health record. That's all automated through an API feed. So the data comes directly from our system into theirs, and they're reading the same note one for one. So we also operate 211, and I did want to mention that. So people with social determinants of health issues, so food insecurity, issues around housing, employment, transportation, utility assistance, we help assist individuals with that through our 211 line. We operate 988, like we said before, and we're partnering with 911. So we're really trying to hit the continuum of all the 3-digit dialing throughout Arizona. And then finally, these are the local lines that we have available to us. So Team Lifeline is available 3 p.m. to 9 p.m. We actually answer this line during the other hours when they're not available. We operate 211 24/7. And then here's our 10-digit number for the state next to 988. And that's it. I think you're up next, CJ.
All right, trying to remember how to share my screen. All right, can you all see that one then? Yeah, okay. All right, thank you, Andrew. And thank you, Margie. A lot of what I normally go over has already been covered, so I'm gonna go a little bit differently through these slides. So Dr. Belfour had mentioned our braided funding, how Access uses contracts to get different kinds of fundings to the REBA so that they can decide what the system needs to really make sure that we have that robust continuum. And this slide kind of just gives a picture of what that means when we say crisis system that's overseen by the REBAs. So a crisis can last a day or two. Dr. Belfour talked about, overnight stay. That could have started at 7 o'clock in the morning with a call to the crisis line. A mobile team has gone out, person goes to a stabilization facility. And then by the next day, there's some discharge planning and work to do. So if a person enters our crisis system, we don't wait to give them that help until we determine who their health plan is. That's what this REBA system is really designed to do. That emergency response, doesn't matter who you are, if you're an Access member or not, we're going to help you right now. For people that are identified within that first 24 hours as being eligible for Access, that transition it happens and it's written into our contracts. The REBAs work with our other contracted health plans. So a person might have their Access health plan is selected as United Healthcare, who does not have a REBA contract. So let's say Mercy Care is the REBA, and their whole system, the Solari team, a crisis mobile team, and now Dr. Belfour is treating them at the stabilization. All of that's covered under that REBA umbrella. And then the REBA and those providers work with that health plan of enrollment to take over that process at the 24-hour mark and continue that discharge planning and ensuring those follow-up services and referrals are all made and those outpatient services can be started. For all the rest of our Arizona residents, we don't have that same kind of continuity when we come to private payer and commercial payers, underinsured and uninsured individuals. We call them non-Title 19 and 21 eligible. So Access has worked over the years to extend that coverage period within that REBA crisis responsibility to up to 72 hours to really make sure that there's no drop in that continuum to get that person all the way through that cycle of a crisis. So here's our statewide crisis hotlines. I do want to mention we do have a text line now here in Arizona. And Andrew, you need to update your slide, get that out there, and make sure people know they can text. We have decided to maintain our own 10-digit number, even though 988 has come out, and I'm going to show you why. I know Andrew showed some data on the utilization there. But in addition to that, we've had these other phone numbers that are county specific or geographic service area specific for many years. Lots of people have these on their refrigerator magnets, in their wallets, in their memories, stored in their cell phones. So none of these phone numbers are going away. With our new single statewide phone number that we have activated as of October 1st, any numbers dialed into those older numbers are just going to route into that single statewide, and we'll monitor those lines. But Access did require the REBAs to keep those lines active throughout at least the first year, so we can see if utilization changes. So when 988 happened, as Andrew said, it's been in the works for several years. There's been lots of crisis providers and community advocates asking for a 3-digit dialing code to access behavioral health services, and we really want to support that. Although we've had this continuum for over 30 years, we want to make sure that we're supporting it, but we can't really just up and replace that statewide system that we've had for so many years. So what we did was we worked on integrating 988 and flowing it in. And Andrew's chart kind of showed you how they flow in. We worked with the Lifeline centers and with SAMHSA and with our REBAs to make sure that these contracts would provide that seamless connection to that standard of care and that continuum that our Arizona residents have come to expect. We're still seeing only about 10% of crisis calls coming into Arizona through 988 versus our REBA lines. This is just an expanded version of the slide Andrew showed, but I've got a little bit fresher data here. And we're going to continue to monitor this flow. So you see in red, that's the REBA traffic that we're seeing. And then the blue is the 988 traffic. And we have seen a little bit of a spike since the 988 go live date of July 16th. September was the first time we saw it really show not just an increase in the Lifeline numbers, but a mild decrease in our REBA numbers statewide. This is pretty interesting because as you can see before, they were as they were moving up, so were our REBA lines. So we had a little escalation 988, but we also had that same escalation. This is good for us. We want people to use our crisis system regardless of how they enter it, but monitoring this allows us to really decide how those resources can be allocated and what we need to maintain. Our overall statewide call dispositions show that we can resolve 87 or 78% of calls into those REBA lines in 988 by phone, meaning the person is in a state of crisis and what they needed to resolve that crisis and maintain safe in their environment was able to be provided by phone. Only 20% of the time are we seeing mobile teams dispatched, and 17% of those times are coordination with law enforcement calling and asking for co-response. And very rarely, only 1% of the time, are call centers reaching out to coordinate with emergency or law enforcement to go out into the community. So that middle one, that's coming in, law enforcement 911 coming into our system, not us going out. And then only about 1% of the time do we identify the need to actually access that emergency resource through the 911 system. And this is a picture of our state and all of our counties. We have 15 counties, but within our state, we also have 22 tribal nations, for a population about 7.2 million. Only 2.4 million of those folks are currently enrolled in the Access program. So you see why it's so important that we have that extended coverage for not just Access enrolled members, but everyone in Arizona for this system to work. These are our total numbers for 2021. Our crisis call centers fielded 428,214 calls. Our mobile teams served 46,746 Arizona residents, and our stabilization facilities served 53,219 unique individuals. That's pretty significant. Whereas in a lot of states that don't have, especially these bottom two, those are usually law enforcement, emergency departments, and jails where those folks would end up. So one of the reasons that we feel like 988 and our crisis system really sees a lot more familiar faces as far as enrolled in Access already, is that Access can't advertise. And even with 988 coming, our federal government didn't give us any money to market 988. So we have partnered with the Department of Health Services, who house our suicide prevention team, and we're able to work with them for them to write in a statewide marketing campaign into the Arizona Suicide Prevention Action Plan. And this is one of their highest priorities, is that first line of getting people a resource. So our 988 marketing campaign is already getting into the works. ADHS selected a marketing firm last Friday, so they were a little bit ahead of target. They haven't made that announcement of who it is yet. But over the next couple of months, we will work with Department of Health Services, that marketing firm, Access, and a couple of the folks from the Solari team to develop materials and really start launching that campaign. So for public marketing out in early 2023. So sometime in January, you might start seeing billboards and on the radio. A lot of folks ask me, what 988's already here, how come we don't see it everywhere? And as Andrew and Dr. Belfour mentioned, with the current routing and so many Arizona residents having cell phones that have out-of-state area codes, we really wanted to give the systems in other states time to build capacity to field the kind of volume that we feel that a marketing campaign might drive. And we wanted those lifeline centers in other states to build those warm handoff protocols, that connection that Andrew talked about. If they can't get a person stabilized on the phone and they need a mobile team and they find out they're in Arizona, they need to reach out to Solari. Well, there's 200 plus lifeline centers across our nation that had to work out those protocols and get familiar with who to call when they identify where a person's at. So there's also the state procurement process that takes a while, but really this kind of falls in line with our strategy to let those other states kind of build some infrastructure, let Solari build some infrastructure too, to be able to handle what comes our way once that marketing hits the street, and then also ride the national marketing. There's been a lot of social media marketing and Samsung marketing, just advertising 988. So to maximize the dollars in the marketing campaign, we really felt like waiting until January would just serve us well all the way around. And that was my last slide. So these are some resources. I know that Ashley will be sending this out. There's some links here that might be helpful to our ADOA is our 911 administration program has set up a page talking about how our PSAPs are working with 988 and our local crisis systems. And then Department of Health Services has published that suicide prevention action plan. So I'm giving you that website there. And I think Tanisha's up next.
Thanks, CJ. I'm gonna share my screen. Good evening, everybody. It's so good to be here and to be alongside so many talented individuals and be a part of this amazing Arizona crisis system. So this right here are three little counties of Maricopa, Gila, and Pinal. While geographically we have a smaller community, we do have more than 60% of the whole state's population in our region. So when we think about the crisis system as a safety net and the individuals that we could potentially be serving, we certainly have an opportunity to support several individuals who might be in crisis. We talked generally our crisis phone line, our mobile teams, and our facility-based crisis services is what makes up our crisis system here in Arizona. In the central region, we have mobile teams that are operated by Taros, MPAC, Spectrum, CBI, and Horizon Health and Wellness, wonderful providers who the goal being the individual calls into the crisis line. The crisis line specialists are working really hard to support that individual telephonically, but sometimes it's not possible to fully support that person through that crisis, or it might be law enforcement who's calling. And so our mobile teams are going to come out to wherever the individual is at with the goal and the idea of stabilizing them right where they're at. For many reasons, it's less disruptive. You can leverage natural supports. I think about folks who have jobs, who have schools, who have children, pets and responsibilities. And so the better that we can support that person in the least restrictive environment, I think is a win-win for the person and for their natural support. These are all going to be two-person teams in our region for optimal safety and engagement. And I have some data later to show that more than 75% of the time we're able to support people right in the community. We can transport individuals to a higher level of care, and I think what's fantastic about that is the last thing that a person in crisis wants to be thinking about is how am I going to get to wherever it is that I'm going? And I've already shared all of my struggles and challenges and what I'm going through with these individuals. So having that warm handoff from the mobile teams to our crisis facilities, I think goes a long way. For those individuals that the mobile teams are really able to support in the community, they can also do follow-ups the next day. They can call the person, see how they're doing. They can set up another visit to come out and see the person. However, we can fully wrap around supports and help that person through that immediate part of the crisis, and then that connection to any additional outpatient supports that they have. We're serving both children and adults. And when I think about children in crisis, I think about the whole family who might be in crisis and how we can really help connect the families to any sources of support like NAMI or the Family Involvement Center. So it's not just addressing the child's immediate needs and issues in the crisis, but the whole family and supporting them. And thinking about our adult members who may have fewer natural resources and supports, how can we connect them to those, again, thinking that short-term and long-term. What we really encourage too is we're training law enforcement and crisis intervention team training when we do our community engagement and making the community aware of these resources, is that there's no one answer that is going to fit every situation. So for law enforcement, if they're going out to a call that they know tends to be these calls at this address for this person, tend to be more behavioral health in nature. We say don't wait until you get to the call, to the location to figure out this really is, I need a mobile team for this situation. They can ask for the mobile team while they're en route, and that way it saves a little bit of time, and then they can hand off to the individual. And likewise, as we're educating the community, these are resources that are available, and calling, starting with the crisis line, at least gets them into that entryway into the crisis system to learn about the other resources and get connected to the right resource at the right time. All of our facility-based crisis services operate around no wrong door. Likewise across Arizona, and I'm sure Johnny will talk about. No wrong door just simply means we're not expecting people to identify, is this a substance use situation, is this mental health, behavioral health. We simply say, and particularly to our law enforcement partners, if you think that this person would benefit from being served by one of our crisis resources, then bring them to us. We want to make it quick. We want to say yes to everybody. We want to be that front door because, again, if you're in crisis, the last thing that you want to have to do, whether you're a parent of somebody in crisis, a loved one, or you yourself are in crisis, you don't want to have to be figuring out, where do I go? How do I get to this location? If you're more rurally located and transportation might be an issue, or you're in the Phoenix metro area, and it just might be challenging to get across town to a resource. We don't want it to be difficult for people. That should be the least of a person's challenge in trying to get care. We offer for our voluntary adult facilities, we have 2 detox facilities in Mesa and Phoenix that are operated by Community Bridges. We have a crisis respite that's operated by RI International. And again, we don't say, particularly for our detox facilities, that the person has to be in that need of a resource. You might have a voluntary adult who just says, I really would prefer to go to this location. They might tell the mobile team, I've been there before and I want to go back to that location. So no wrong door, getting people to the right place at the right time. We have several adult involuntary and voluntary facilities throughout Maricopa County and in Pinal County and Casa Grande. They're spread across the county, so from Peoria and Avondale, Phoenix, Mesa, to really support both individuals who are brought in involuntarily as well as voluntarily. So where family, caregiver, guardians, clinical teams, mobile teams, law enforcement might have filed an application for emergency admission and really believe that this person could benefit from care, but they're not willing to seek treatment. This is where our individuals would come by law enforcement to one of these facilities, and more than, I would say, about 75% of the time, people coming into our facilities are voluntary, and we work really hard to convert those that do come in involuntarily to voluntary treatment. We have 3 children's crisis facilities we're very proud of to have these. We opened them last year, and we have 2 in Phoenix and we have 1 in Mesa. And thinking about our young folks, and again, the last place that a child with behavioral health needs, the last thing that they need is to end up in an emergency department, especially one that doesn't have a pediatric behavioral health unit attached. And so often parents, they call their insurance company, and the insurance company says, oh, take them to the nearest emergency department. And then it's just infinitely more difficult to get that child to a location with a pediatric behavioral health inpatient. Whereas with our children's crisis facilities, we're really helping to support the immediate nature of that crisis situation. And if that child really does need to go to a higher level of care, then they're in someplace safe. We're getting mom, dad, guardian, caregiver, kinship. We're getting support for them. We're also working to get that child connected to additional supports and transfer them to a higher level of care if need be. So some of our stats, our crisis line has done a phenomenal job of not transferring calls over to 911 unless necessary. And certainly if there are indicators of violence or safety, we want to make sure that both the individual who's in crisis as well as the mobile team are safe. But we, less than 1% of the time, the crisis line is having to transfer calls back over to 911. And these are our stats around the 911 diversion. Andrew talked a bit about it. It's really just fantastic to think about the work that we've done. around 911 call diversion. So often people don't know what the resources are. They don't know how to get to the thing that they need. And even some folks who might be experiencing that first episode of psychosis or delusions might truly believe somebody's breaking into their home or they're being stalked or surveilled. And so they do call 911. So in these opportunities that we can transfer that person over to the crisis line, or we can get that mobile team going out with law enforcement, is every opportunity to get law enforcement back out into the community and individuals in crisis to a different resource. You can see our mobile team data year over year. Adults, there are more adult mobile teams for adults than children. Schools and family tend to be higher requesters of mobile teams for kids. And you can see our average mobile team response time. We prioritize law enforcement, again, trying to get them back out to the community. And we have certainly increased law enforcement utilization of our mobile teams as well. Year over year, law enforcement continue to divert individuals to our behavioral health crisis system increasingly. Last year, it was more than 28,000 individuals were diverted by law enforcement to either our mobile teams or to our crisis facilities. And even though the community might be accessing some of these resources in a less so, we still see law enforcement continuing to have engagement with individuals who are in crisis and diverting them over to our crisis system. Really want our average drop-off time for law enforcement to be 15 minutes or less, and as you can see, it's year over year. We do a really good job, our providers do, in trying to get individuals that warm handoff from law enforcement super quick. We look at how people come into our crisis facilities by law enforcement, by petition, pickup order, and voluntary. We look at which agencies are dropping off so that we can see if there's any trends. We see which resource law enforcement are using of our facilities and our mobile teams. And as you can see with our law enforcement diversions, again, year over year, it's increasing, that we're getting more people diverted by law enforcement. We really want to emphasize law enforcement as last resort, the no wrong door philosophy. We want to address issues when they come up, and working together. I'm so passionate about CIT that I probably could spend like a whole evening just talking about that. But suffice it to say, I have had the pleasure of being part of a system that has trained law enforcement for a very long time, since 2014, when Mercy Care became the regional behavioral health authority in the Central Region. We've trained over 1,700 law enforcement and crisis intervention team, participation from local, county, state, federal, tribal law enforcement representatives. More than 25 law enforcement agencies have participated in one of our 3 CIT programs, either by sending people through or actually holding the class and the 40-hour class. We have 1 week every month where we're teaching CIT to officers. And in the past couple of years, we've included call takers and dispatchers, constables, fire. Gosh, there's so many folks that have been able to be a part of this training. Our collaboration with our CIT coordinators or individuals who are designated by each police department as their go-to, so that we can problem solve those issues. If police are going out to the same location routinely, if they're seeing the same person, then we want to know. We want to look at our familiar faces in the crisis system and from law enforcement, so we can, let the health plans know, let our providers know, to really support individuals a little differently, so that they're not constantly using 911 as a resource. lots of community events. We're trying to get the word out and make sure that people know that crisis services exist and how to access them. And lastly, I think what's really important in our education with providers in the community is helping folks to develop those at-risk crisis plans or safety plans. So you can't ever always anticipate what that crisis is going to look like or when it's going to happen. But when it does happen, what would you want our crisis providers to know to better support you or your loved one? What would you want first responders to know to better support you or your loved one? So along those lines, we really try to support people as best we can. So with that, I will pass it over to Johnny, I believe.
Thank you, Tanisha. I will start and I will do my best not to sound too repetitive. I know systems are quite similar through our regions, definitely with the continuity, particularly with the statewide crisis line. There is a lot of similarities. So I'll do my best to make sure we touch on some new stuff for the group as well during this portion of the presentation. So structurally, for Northern and Southern Arizona, like Tanisha said, with Mercy covering Central, there's effectively two different regional behavioral health authorities. That's Arizona Complete Health and Care First. There's still physical health and behavioral health Medicaid providers for the non-SMI identified population that's rendered by Health Choice and or Blue Cross, United Healthcare, and Banner University for Northern and Southern Arizona. And again, we'll be focused here on just North and South on our REWA operations. So what's unique to Northern and Southern Arizona is that we service a number of tribal lands. So it's important to highlight as we look at this map, large communities, vast environments for travel time, particularly as we talk about crisis mobile team services. But in addition to that, we work heavily with our tribal communities to ensure that we are effectively able to provide that level of support, both within the county as well as on tribal nations. So just to keep in mind, we're working heavily to ensure that statewide, no matter where you're receiving those calls from, when Andrew and his team at Solari pick up, we're able to offer the full array of support that the state of Arizona has in place. That includes crisis mobile teams, observation unit services, et cetera. And I know we've heard this quite a bit, but I don't think any of us can stress it enough, right? Everybody's eligible for crisis services. Thank you to Access and the way that Medicaid blends our funding. So regardless of insurance eligibility or status, we're going to render those crisis services. And again, crises aren't really defined, right? Just anything outside of a person's ability to cope does not mean just somebody who's danger to self, danger to others, actively psychotic. We want to support any individual that needs that level of care. Even if it is just telephonic, anxiety, depression, et cetera, we definitely want to be as heavily involved and allow these individuals to access the system as easily as possible. Like Tanisha mentioned, no wrong door is certainly the policy that we're all focused on statewide. That means it is 24/7, 365. They should never refuse an individual who needs care. The individuals should never be turned away from an OBS unit or denied a crisis mobile team if they're requesting that level of in-person support, or if they need to spend additional time talking to somebody on the crisis line. We're fully focused again on community stabilization. So as Margie, Director Belfour mentioned early on here, right, we are focused on the least restrictive but clinically appropriate settings. So that is certainly why there are different levels of care here, from telephonic to in-person to facility-based. We really want to work together to make sure that we're working in the most clinically appropriate environment, but again, the most least restrictive as well. We do offer real-time escalation, which I'll highlight there at the end as well. For Northern and Southern Arizona, we have a work process in place to ensure that you have access to our teams 24/7 should anything go wrong, and you need that level of escalation or support. That certainly exists in place as well. We have community liaisons that reside in or partner directly with the counties that we're servicing. Know that there's a number of counties, again, quite large. So we have a liaison dedicated to each community specifically. So Bill Mitchell is still in training for Coconino and Yavapai County. We'll list his contact here and update that for the group here in the near future as well. But for every other county, we have a first responder liaison that works traditionally not only with those first responders, but also with all the system and partners that we encounter. So if there's ever an issue, questions about the system in your particular community, you're welcome to contact these individuals. They are the subject matter experts for each county that they serve. and work directly with their community members to establish kind of those coordination of cares, offer crisis system overviews, trainings, and really just function as the point of contact or face for each community that they serve. This is kind of mirrored to what we've heard as well, but the important piece is kind of highlighted at the bottom. Not only are we here to support the community, reduce detentions, hospital or emergency department visits, and that involuntary psychiatric treatment side, we are also partnered with the 911 system, also with that no wrong door. But just to highlight here, we issue county-specific crisis protocols. These are reference guides for any community member. They are updated annually and signed off by system partners that include county attorneys, county behavioral health, outpatient service providers for behavioral health, physical health providers that have partnered with us in crisis system meetings, as well as all of the health plans that we can get in contact with and establish those partnerships with in each region. These are updated again annually. They're going to be established for Northern Arizona individually here in the near future. We are new to Northern Arizona, but certainly not new to the REBA, or we're new to Northern Arizona as a REBA, but not new to Northern Arizona as a healthcare provider up there. So we are still establishing those protocols at this time. We hold quarterly crisis and county crisis specific meetings. These are where those protocols are built from. They're open to anybody who'd like to attend. If anybody wants to get on one of those or even establish an agenda item for an update in the community, you're welcome to reach out to those county liaisons. They will make sure that you have the invite, or myself, and we'll make sure that you have the capacity to attend. And then we also issue crisis materials for both Northern and Southern Arizona that include our crisis cards, flyers, and law enforcement guides to crisis that include kind of triage protocols as well. So the who's who. Andrew, as he mentioned, quite a number of times, right? We have a statewide crisis line provider with the listed HOPE number, but in addition to that, linked directly into the 988 system. We have crisis mobile team providers established for each county. So for Mojave, we have Community Health Associates, Teros, and Community Bridges Incorporated. Yavapai, we have Spectrum, Coconino, Teros, CBI, and Spectrum. For Navajo and Apache, CBI. And then for all of Southern Arizona, we have partnerships with CBI and Community Health Associates, or CHA, to provide those services. Observation units, there are a number of units. We are lucky in both North and South to have a number of smaller units that generally have attached non-IMD, so inpatient facilities, so they can conduct or take individuals who are both voluntary and involuntary and conduct quarterly evaluations. And then we partner directly with a number of behavioral health inpatient facilities to ensure that we have effective throughput as you engage with those OBS units and need higher levels of care. System and practice, and this is going to mirror Margie's slide because we worked together on this quite some time in the past. Oops, too far. So system and practice, as we mentioned, the vast majority of the contacts coming to the crisis line are resolved on the phone. The majority of our contacts coming into the crisis line are individuals themselves calling into for that level of assistance. Our crisis mobile teams in Southern Arizona are resolving just over 70% of those calls in the field, so without a need to go to a higher level of care, including observation units. And then those two stats are relational, right? That 20% that aren't resolved on the phone are going to the mobile teams. However, law enforcement does do a number of drops to our crisis facility, and we certainly have walk-ins throughout Southern Arizona and Northern Arizona. Currently for Southern Arizona, around 68% of them are discharged back into the community, and they remain stable about 88% of the time. That's pooled based on inpatient claims that we review as a health plan to ensure that our OBS units, crisis mobile teams, and crisis lines are doing an effective job stabilizing at such a high rate. So I'm just going to highlight some tools. Certainly we've gone over kind of what the CMTs are, but some of the advantages that they have and support models that we put in place. We do have those response time limitations placed on us by access. So in metro or urban communities, we're looking at 60-minute responses, 90-minute response requirements in rural. We certainly require it closer to 60 for all. For law enforcement, we look to reach 30-minute response times. Current response times for all of Northern and Southern Arizona since October 1st until the 26th, so this last month, we're about 37 minutes. We leverage in our more rural communities, we leverage co-locations to get to calls faster. This allows us to often correspond as well, since we partner directly with a lot of the police departments or 911 communication centers for those co-locations. So that way we can get to know one another, ensure that we're diverting more calls off of the law enforcement, fire, and EMS system, as well as dispatching effectively in more rural environments. We offer critical incident stress management via those crisis mobile teams. This is available 24/7 as well. What that is it functions as more of a scheduled. We can also offer it in real time, large, due to a community event, a large response from our mobile teams with unlimited number of availability. So we have established this in our emergency departments during COVID due to some of the trauma that those workers experienced. We have offered this more recently at the University of Arizona, and we've also offered this to elementary schools and to other system partners, including outpatient providers when they experience an adverse event. So we are always happy to schedule that. Please reach out to us anytime 24/7 to get a system scheduled so we can offer more extensive support in a more group environment rather than that more one-on-one involved crisis response. We also offer peer response and crisis aftercare. This is linked directly to mobile teams, OBS units, and the crisis line. This is available. The referrals can be made 24/7. They're made through these crisis providers to ensure that there is aftercare or wrap services for individuals engaging directly with the system. And then one of the nice things on the side that we're highlighting and will expand into Northern Arizona here in the near future is a bed availability tracker for us. So that way when individuals are in need of a higher level of care, our mobile teams have access to this 24/7 so they can try and find effective placement for those individuals. All right, crisis units, and I keep clicking twice, I apologize. Crisis units, as Margie, the expert, mentioned. These are known as OBS. We have a number of them. Note that Navajo, we have CBI Winslow with licensed chairs on a non-IMD inpatient unit, so they're kind of dual purposed. But we have a number of units that take those drop-offs. They take law enforcement drop-offs, walk-ins, community referrals, as well as crisis mobile team referrals into the units for further evaluation. They all function with no wrong door policies. They often partner directly with non-IMD or IMD inpatient units for individuals that need higher levels of care. And some of the nice features that we've also added in Southern Arizona that we're expanding into North currently are urgent engagements. We ask our outpatient providers to respond within 1 hour to assist with enrollment and coordination of care. And My Health Direct, which is an online scheduling portal, is going to be coming back online here for Northern and Southern Arizona. That allows us the capacity to identify 24/7 availability for intake appointments, post-crisis follow-up appointments, and behavioral health medical professional follow-up for those that are already enrolled with an outpatient service provider. We also offer a number of trainings. If any of these garner any interest from the group, please do not hesitate to reach out. We partner to offer these trainings to multiple community members. That's crisis system overviews, so a more detailed version of what we're looking at today. We offer resiliency, which we previously had only offered to our first responders, but have since expanded this out. And again, realistically during the pandemic, with the identification that we needed to ensure that we were offering some additional skills to our system partners, including the hospitals and outpatient providers. We do trauma-informed care trainings, mental health first aid, which I'm sure a number of the group on the call are familiar with. And we also partner directly for CIT training as well, which Tanisha mentioned. Well, probably the most important slide beyond knowing the numbers and the linkage into 988 is that if you ever encounter a problem, if something doesn't feel like it's going well in any county that we service, you can always get in touch with a member of our team 24/7. We have an on-call. Simply ask to speak to a lead at the crisis line. If you're still having troubles, please ask for the Arizona Complete Health or Care First on-call. For any critical incident notification, for any issues in the community that you feel need to be resolved, you're welcome to speak to us in real time. A member of our team is available 24/7. If it's non-emergent and you still need some support or help, or you have some additional questions after today that come up with a county-specific kind of lens, please contact the liaisons listed initially, and our slides will be provided. And you're also welcome to contact me 24/7 with a short description of the events. That way we can reach out and do our research. That is all for me. Thank you.
Okay, so we'll move to our question and answer portion. And so just looking in the chat there, the Q&A chat, our first question is, do the commercial health plans contribute to this system or pay for services if provided to their member?
I can make a stab at that, and if others have info to chime in, feel free. Right now, most private insurance does not pay for crisis services. If you are interested in advocacy, I think that's a very important, like, mental health parity issue. And there is legislation that was circulating on the federal level this past year, and it should be in the next legislative session as well. That would actually require all health plans to reimburse for crisis services. There are, as we at Connections, because we operate our observation units, we have individually approached some private health plans and negotiated with them, because once it does make sense, it's like what we talked about in the beginning, it makes good financial sense to have these crisis services that keep people out of hospitals. And so on an individual basis, we've been able to negotiate some stuff around that, but for the most part, not so much. But I'm going to put a link in the chat, or I don't know how to, I'll put a link in the answer to NAMI, National Alliance on Mental Illness. They have their Reimagine Crisis website that actually is a good place to go and sign up for alerts if you're interested in advocating, for legislation that would support that.
Thank you, Dr. Balfour.
Oops.
We also have another question here. Should we be telling our teen patients about 988, or is it best to have them call the teen line?
Say either one of those would work. From my standpoint, the team over at Teen Lifeline is amazing. They're peers, so generally when I give out the number to teens, I'm letting them know the difference. If they're more comfortable speaking to peers, I think they generally are. That's where they start. If there's ever issues, calls can be transferred over to us. We can help get mobile teams out, and that system is completely integrated with us. So I would give them both and let them know the difference between the two. One will be adults, one will be peers, and let them make the choice.
Yeah, and just wanted to mention that in the South, in terms of like the facilities, the CRC, the Crisis Response Center in Tucson, also has a youth unit, which has an urgent care walk-in component, as well as the overnight 23-hour OBS. So that's an option as well for the Southern folks.
Okay. We've got a question, Dr. Bloom. I don't know, Dr. Bloom, if you're available to speak, but I'm not sure what question you're asking there. So if you want to see if you can unmute, I'm not sure if that's possible. Maybe that'd be the easiest way, or if there was something you had to contribute there.
He should be able to unmute now.
Okay. It's a very interesting presentation. I've been here not too many years in Phoenix, and it's very hard to get a comprehensive picture as to what goes on here. But I understand that, and I'm also a forensic psychiatrist. So you do a portion of the work for the civil commitment process. And I think you do. And then you either release people or they go voluntary, or you send them on to the next level for further evaluation. So do you have any breakdown, and are those mostly the people you showed the number of people that are brought in by the police, and the percentage of those people that are in the civil commitment process? That's one question. And I have lots of questions about follow-up studies on the people. I mean, you obviously are doing a very good case finding system, but what about on the other end, after these people come through these short-term evaluations? What happens? Who's following up? I'll stop there. I have plenty of questions that come up from your presentation, which was very helpful.
I can answer part of that. I think this will be a team effort on answering all that. but as far as people being brought to the facilities in the civil commitment process and like how law enforcement is in that, that's actually something, you know, with us having a facility in Tucson and Phoenix, there's differences in that. In Phoenix, the majority of the law enforcement drop-offs are people who are in the civil commitment process, like under an emergency application, for example. In Tucson, the police have a lot of mental health programs and a lot of training around outreach and things like that. And so they actually bring in a significant portion of voluntary people that we don't typically see that up in Maricopa. So that's one difference. And then, yes, like you said, the goal is to try to stabilize them and try to get them, you know, to engage in treatment so that they can continue it on a voluntary basis, you know, by you know, trying to form a therapeutic alliance with them. And so that's one of our metrics is conversion to voluntary. So if they came in involuntary, whether they ended up discharging to the community or went on to the hospital, what percent were able to continue as voluntary. And that's usually around 60% or so.
Okay, just, I won't take up too much of your time. Just follow-up studies on people who come in, have short-term work in the system, then go other places. I know from my very short experience in this state that there's very few data systems that you can do longitudinal studies of what actually happens to people. Maybe I'm wrong there. I haven't been able to find any in the forensic system. But what about your very large group of clients? Do you do, or can you do any follow-up studies on how they do after the short-term intervention?
I'll take part of that. So we look at readmissions to see if people are come back and they're cycling through. Now, us as a single provider, we don't get the whole picture because we could discharge someone and then they could go to another facility. So it's more at the REBA level or the access level to look at, you know, really what is the readmission rate. And that's why Johnny showed that stabilized in the community rate, and he can maybe talk about how you track that. But yeah, I mean, that's kind of where we're at in terms of following up how people do. And then there are a group of people who cycle through a lot, which you heard some of us refer to familiar faces. And so there's various programs in place. You know, like we do one with our repeat people at the CRC to look to see, well, what can we be doing for those people that is going to get their needs met so that they're not cycling in and out. And there's pockets of looking at like this familiar face type thing throughout the system. Like there's a frequent 911 callers group, you know, that collaborates around that. There's, you know, we look at the ones coming to our facility over and over again. There's some frequent jail users type things. So there's pockets of those kind of high utilizer like reviews kind of all throughout this for different systems.
Yeah, this is Johnny. The only thing that I'd add to Dr. Balfour's comment is that's correct. We leverage claims data to get additional detail. And the way that functions, right, is since we're the initial payer for both the crisis line and crisis mobile team, as well as OB services, we have some level of insight if they are plan members into what the rest of their claims are. So we do look at claims utilization post each of the crisis touches. So crisis line, crisis mobile team, OBS to try and establish kind of member trends and baselines and utilization, as well as, you know, how effective service provision is.
I just want to offer up just a tiny, I want to go back to the first part of the question, that in the central region, we do a lot of training with law enforcement. We have a lot of resources for law enforcement. Many of the individuals, and very consistently, law enforcement are bringing them in voluntarily. But there are individuals who have been an application for emergency admission, either emergently non-emergently, somebody is recognized that somebody is in need of care. And so we do see of equal volume, law enforcement bringing people in by their petition as well as by those pickup orders. So it's complicated. 25% of the people who come into our adult involuntary and voluntary facilities are coming in involuntarily, but we're also able to convert about 72% of the time those individuals from involuntary to voluntary.
Thank you.
And Dr. Bloom, just as a follow-up to like studies, we do have a system, an integrated system of care team here at Access is working on creating some type of a tracking so that we can look from a statewide level. The way our involuntary or civil commitment process works here, it starts at the county level. And not all of those counties have the same type of an agreement with Access or our regional behavioral health authorities to manage that process in whole. In Maricopa County, we do have a full, we call it an IGA, an intergovernmental agreement. So Mercy Care can see a lot more of that picture. In Southern Arizona, they have a partial, but they have a collaboration group where they can see that. But in other parts of our state, we do not have that same kind of clarity. So statewide follow-up on the percentage of those, what happens to this person after civil commitment, especially if the only reason that they are receiving Access or REBA funding is because of the civil commitment or court order treatment process. Once that expires, where they go. We definitely, our partners at the Department of Health Service are very interested in creating some way that we could really look at those outcomes, but I'm not aware of any database that you could use to do that kind of follow-up at this time.
And just to throw it out there, because I'm a nerd, there's a group that we're working on an actual, like a rigorous research study in collaboration with ASU, because they have a database of Access claims that's been linked to various things. And so we're actually, doing a research study with the intent of publishing it in an academic journal to get at some of these questions.
The lack of centralized databases in this state has a lot of people flying in the dark. It's everybody. So I think what you said, Dr. Balfour, that maybe the REBA should have a centralized database on these people who are going in and out of different agencies. And I mean, they could be in your agency and then in another place and another place. It's a general problem. I won't comment more about it, but that seems to me to be a step that the state ought to take to try to understand exactly what's going on with people.
Thank you, Dr. Bloom. Thank you to the panelists. I want to make sure that we're respectful to our panelists' time for giving this presentation. I wonder if we can just quickly answer this last question we have. Do you have separate mobile teams for children, or are teams established so they can see children or adults?
I think both Johnny and I would probably answer this very similarly, that all of our mobile team providers they're meant to be able to serve all individuals. And while some might have more of an expertise working with youth, working with veterans, working with elderly, all of our mobile team providers are expected to have a good cross ability to serve all individuals. So we don't have separate, in the central region, we don't necessarily separate teams out by adults or children.
Yeah, and this is Johnny. Similarly in South and North, and a lot of that links back to kind of leveraging proximity-based dispatch and availability. We don't want to have anybody wait, right, for a specific team, and we want to make sure that we can always send the team that is the closest. because when we do that, right, we get the fastest response times to try and address that crisis in as real time as possible. So our expectation is similar to Tenacia. We would hope that our teams, and we expect that our teams can service all individuals in the community, regardless of specialized or specialty population.
Okay, thank you. Just want to say thank you to our panelists. We really appreciate this education. I know for me, I can't think of another time where I've had such a clear global presentation of what this actually looks like, and it was very, very helpful for me. So just want to thank you again for your time, and with that, we'll go ahead and close the meeting if there's nothing else that any of our panelists had to say to close out. Are there any other comments before we end the meeting?
I'm just going to go ahead and.
Yeah.
Oh,
just
sorry,
say
go ahead.
feel free. I think all of us would say feel free to email any of us if you have any further questions.
Really appreciate that, Dr. Balfour. Thank you.
Sorry, Ashley.
I'm just going to go ahead and share the CME information on a slide for anyone who wants it. The CME information I will email out to each of the participants so that you guys do have the info on how to claim it. And if you guys have any other questions, feel free to reach out.
Okay, thank you, everybody. Have a great night.
Good night.
Good night. Thank you.
Thank you.